This retrospective cohort study by Wang et al. Presents a clinically significant refinement of thyroidectomy via an oblique supraclavicular incision through the sternohyoid-sternothyroid intermuscular space. The study rigorously compares this approach, n equals 204, against conventional Kocher, n equals 202, and endoscopic, n equals 102, techniques in 508 unilateral thyroid cancer patients. Key strengths include its robust methodology, a substantial sample size powered for subgroup analyses, standardized surgical protocols, validated outcome metrics, VAS for pain, PSAQ for scar satisfaction, and comprehensive assessment of functional, oncological, and aesthetic outcomes. The supraclavicular approach demonstrated superior perioperative outcomes, including shorter operative time, 36.74 plus or minus 3.01 minute versus 41.05 plus or minus 6.46 minute for Kocher and 105.67 plus or minus 10.16 minute for endoscopic, reduced drainage, 18.69 plus or minus 8.99 ml versus 46.57 plus or minus 12.78 on 25.5 plus or minus 17.81 ml, and significantly lower neck discomfort, 12.204 versus 44.202 in Kocher group, p less than 0.01. Crucially, it maintained oncological equivalence in central lymph node dissection, 4.65 plus or minus 1.26 nodes, and complication rates while offering enhanced cosmesis, smaller incision, 3.77 plus or minus 0.29 cm versus 4.68 plus or minus 0.76 cm for Kocher, and superior long-term scar satisfaction. PSAQ 11.58 plus or minus 2.31 versus 15.24 plus or minus 0.94 at 3 months, p less than 0.01. The study's most compelling contribution is its anatomic innovation, leveraging the avascular plane between strap muscles to minimize tissue disruption. This technique reduced flap dissection area by 58.7% versus Kocher, translating to better preserved cervical sensation and function. By avoiding linea alba incision, it mitigated adhesion-related morbidity while obviating endoscopic costs and steep learning curves. However, limitations include demographic imbalance, endoscopic cohort younger. P less than 0.01, potential selection bias from single surgeon design, and lack of long-term oncologic follow-up, greater than 36 months. Despite these, the authors successfully validate this approach as a cost-effective middle ground between open and endoscopic techniques, harmonizing radical resection with patient-centered recovery. Future multicenter studies with extended follow-up will strengthen clinical adoption, but this work already offers a pragmatic advancement for thyroid surgeons prioritizing both efficacy and quality of life outcomes. This study, reviewed by Dr. Reza Lankarani, general surgeon and founder of Surgical Pioneering Series, reviewed by Dr. Reza Lankarani, general surgeon and founder of Surgical Pioneering Series. To access additional details, please refer to the Surgical Pioneering podcast series application available at the following link.